So much. Thank you for the kind invitation to Dr. Mustafa, my friend Dr. Osman, and also Dr. Omer, and the rest of the organizers. I'm delighted to be here. My first time in Egypt, and hopefully I'll come back for another trip. So what I'm going to talk about today is prostate cancer Theransotics, but not PSMA. These are my disclosures. So I start with this slide. Let's see if this works. That basically shows you what we try to do here. Is there a pointer here? Yeah. Yeah. This one. Oh, perfect. Perfect. Thank you. What the goal of treatment care is across time when a patient is diagnosed with cancer, in this case prostate cancer, as that patient goes through the journey of diagnosis and treatment. So at the beginning, of course, when the cancer is localized, the idea here is to try to go for cure, if possible. But then later on, when that doesn't work, there is a locally advanced cancer. The goal of the treatment, of course, at that time is to try to delay the metastatic disease as much as possible. And then as the patient goes through development of metastases, metastatic castration-resistant prostate cancer, for example, then the goal is really depending really mostly toward delaying death and improving quality of life. So we really have to pay attention of where we are in this panel in care of our patients. And as you know, radiopharmaceutical therapy is becoming a new pillar here, which I don't have it here, but the pillars of treatment are usually surgery, radiation therapy, molecular targeted therapy, and immunotherapy, for example, and now we have radiopharmaceutical therapy, which is becoming much more important. So there are still a lot of things to do in cancer treatment. And that's why we have an unmet clinical need for development of new options. And they don't have to be radiopharmaceutical therapy. One of them is radiopharmaceutical therapy, but you can think about new cytotoxic drugs. You can think about the CAR-T platform or antibody drug conjugates in this case. Now, here is basically a natural history of prostate cancer, and you can see that prostate cancer is a very heterogeneous disease. So you have basically normal cell lines in here, and then if they become cancer, there can be multiple different clones of cancer that develop at one tumor focus, and this could be a different tumor focus. These different colors basically show different clones of cancer within even the same tumor. So you can have, in the prostate, you can have a tumor here, which is, for example, much more aggressive down here, or you can have another tumor, and that's actually typically the way it is. The cancer, prostate cancer is a multifocal cancer. And that cancer, you can see that is a different Gleason score and different clones. And then at the beginning, when you see that there are different clones that are being metastasized, and then as time goes on, when the patient gets into biochemical recurrence, maybe one of these clones become more activated and go to different sites. And then when the patient is treated appropriately, then there is new pressures of treatment to that cancer, and new clones will develop. And then some of these clones become more aggressive, and then they go to other places. So this is a very dynamic structure that as time goes on with prostate cancer. And at every point of this interval, there is really need for understanding of what is going on with the prostate cancer to treat it appropriately. So here is another schematic of the natural history of prostate cancer, and you can see basically we have three different phases. This is This is the initial staging phase, and then we have the middle phase, which is the biochemical recurrence, and then we have the metastatic disease. And as you can see right now, PSMA is very important. It actually participates in all three phases of imaging of prostate cancer. And you can see what has been approved, at least in the US. We have gallium-68 PSMA 11, the DCF-PYL, which is marketed as Pylarify, and then we have the radio-hybrid version, which is Posluma. And again, it's very important. These are FDA approved for initial staging, biochemical recurrence, and of course, you need to know if the target of PSMA is there if you're considering patients for radiopharmaceutical therapy. And then also I mentioned the idea of oligometastatic disease that you can have at each of these phases. These are called oligometastatic disease, usually defined as 5 or fewer metastases, but these are different from each other biologically. This oligometastatic disease, synchronous oligometastatic disease, is biologically different from metachronous oligometastatic disease, and that is biologically different from induced oligometastatic disease. And each one of them really requires different treatments. This one is more aggressive, of course. Now, with regard to the treatment landscape, I showed you the molecular imaging landscape. You can see that this is really crowded. You have a patient is again diagnosed in here, and then you have biochemical recurrence, and 2 of them at least, or 3 of them. And then as the patient goes across this journey, you have different types of treatments that have been approved, and these are all the clinical trials that have resulted in approval of different agents. And then you can see across all of these clinical trials and different treatments, we are down here. We are in the Alsimca was the trial that resulted in radium-223 approval, and now we have the Vision trial, which resulted in approval of Lu-PSMA. So we are really at the end of the spectrum in here. And of course, as you know, there are many clinical trials going on to push this envelope a little bit earlier in the treatment of these patients. Now, let's start with FDG. Now, FDG, I worked on this actually maybe about 10 years ago, 10 or 12 years ago. This was an NIH-funded study. We looked at metastatic castrate-sensitive prostate cancer, and then we recruited a number of patients and tried to see if the information that is embedded in FDG PET-CT is prognostic, and in this case, in fact, it was. So we defined what's called sum of SUV max, the parameter sum. This was the sum of the 10 most active lesions that you see on the scan. And then we followed these patients, and you can see if you put them in quartiles, the patients who had the lowest sum score did much better than the patients who had the highest quartile of sum. So these patients did not do as well. So in these, basically these Kaplan-Meier curves really showed that the information on FDG PET-CT is useful in detecting prognostic information. And in this case, the prognosis was predictor of time to hormonal treatment failure. In other words, can we predict when a patient switches from a metastatic castrate-sensitive disease to a metastatic castrate-resistant disease? Because that's a very major transition in these patients. Different treatments, and also, as you know, the prognosis gets a lot worse. Now, we did the same thing for metastatic castrate-resistant prostate cancer. Again, same parameter, sum, as a predictor of overall survival. And again, if you put them in quartiles, you can see that the patients who had the 4th quartile, they did not do well at all. And in fact, when we looked at the sum parameter, if that number was more than 20, the hazard of death really dramatically increased. Again, the information of FDG PET-CT was useful in predicting overall survival in these patients. Then we also looked at and see if the information on FDG PET-CT is useful in prognostically useful when the patient goes under different treatments. So we looked at 47 men with metastatic castrate-resistant prostate cancer. We did FDG PET-CT at baseline and very early after chemotherapy, only 4 months. Why 4 months? because the medical oncologist is very interested to know very early on if the treatment is working or not. They don't want to wait a year from now to see what's going on. They want to know, if you can tell them tomorrow if the treatment is going to work, even if you give the first dose, they would love it. And then, so we did that 4 months, and we looked at PSA, which is, of course, a non-imaging parameter. We looked at RECIST 1.1, which is based on CT. We looked at PERSIST 1.0, which is based on FDG PET-CT. And then we combined the PSA non-imaging with PERSIST. And it turned out that when we do combine FDG PET-CT information and PSA information, we get the best result in separating the patients who do well versus the patients who do not do well at 4 months of treatment. Now, this was also later on, much later on, used by the group in Australia. So in the Loop PSMA trial and the therapy trial, which was led by Mike Hoffman at Peter Mac in Melbourne, they actually, their eligibility criteria included not only PSMA, but also included FDG. So they mentioned that if the PSMA is negative and if there is FDG positive patient like that, this patient is not eligible for radiopharmaceutical therapy. If the patient, if there was some discordant FDG positive disease, you can see some of these disease that is discordant, they also excluded those patients from these trials. However, if there was concordance between the imaging or there was PSMA positive, no FDG positivity, they considered those patients to be suitable. And basically, they really trimmed and maximized the possibility of treatment response in these patients. And as you know, by the way, Vision didn't do that. Vision basically did not do FDG. They just did PSMA positivity. So in general, in Vision trial, you could have patients like this, and you could have patients like that. Both of them were possible. Actually, all of these three were possible. And that's why when the trial was finished, you can see that the response in therapy trial, which excluded this group, was better in comparison to Vision trial, which basically did not look at this because they just didn't do FDG PET-CT. They didn't know. Okay, now we move on. We studied the FDG, the most common tracer. Now we're going to go through not all of these, but some of these basically new biological targets that we can think about. So let's think about gastric releasing peptide receptor. Now there are 4 different versions of this. The one that is useful to us is this bombesin 2 or gastrin releasing peptide receptor. It is overexpressed in about 50 to about 100% of metastatic cancer-resistant prostate cancer, and interestingly also in patients with neuroendocrine differentiation of prostate cancer. And there are different tracers that have been designed, either agonist or antagonist to this receptor. And it turned out that the antagonist is better because it's associated with less adverse events. Now, the one that has been really studied, there are many, many tracers, but the one that has been really studied is RM2 that I'm going to talk about. So this is one of the first that was published. You can see the biodistribution of this RM2 tracer. This was labeled with gallium-68. And you can see that, really not much salivary gland uptake. There is cortex of the kidney uptake, and there is pancreatic uptake. Now, you might think that if this becomes a theranostic platform, perhaps the pancreas is going to get a lot of radiation, but it doesn't. In fact, it washes out in time, and I'll show you a little bit later. So you can see that the pancreas uptake is kind of going down in time. So the group from Stanford, they looked at this and they saw that as the PSA goes up, the uptake in the RM2 goes up, so that just like kind of PSMA, you can see that the patients who had positivity, PSA velocity was shorter. They had a higher higher RM2 uptake. And these are some of the examples. You can see that, for example, here's a primary tumor. There's a node in here in this patient. Now, again, the group from Stanford, they compared PSMA PET-CT and RM2 PET-CT in the same patients. And in some cases, PSMA was better. You could see more on PSMA than RM2. And in some cases, RM2 was better. In most cases, PSMA was better. But in a number of patients, actually, there was additional information that was provided by RM2, which makes sense. There's a lot of heterogeneity in prostate cancer. So, for example, these adrenal glands were very nicely seen on RM2, but not PSMA PET. And interestingly, this is another study from Stanford. This is the same patient. So this is the same patient who had a PSMA RM2 PET scan here. This is a PET-CT. You can see there was a focus in the right peripheral zone of the prostate. And that same patient had an additional PET MRI with gallium-68 PSMA 11 and had another lesion in the left peripheral zone. So this same patient had two focus of prostate cancer. One was seen by one agent and one was seen by the other agent, but not both. Now, this is another interesting study, again from Stanford, and they looked at the expression of GRPR in metastatic castrate-resistant prostate cancer, and they did a head-to-head comparison with gallium-68 PSMA 11, and they really interestingly noticed that there was concordance only about a quarter of patients. A lot of patients, 75% of patients did not have concordance between these studies. So for example, here's one case. You can see this is the PSMA PET. Liver is kind of high uptake. There was a lesion in this patient that was very nicely seen RM2, not seen at all essentially on the PSMA PET. And is it possible to use RM2 for Theransotics for treatment? And this study showed that the answer is yes. So this is from Germany. So this is a patient who had a RM2, gallium-68 RM2. You can see the pancreas in here. And these are multiple bony lesions. Same patient received these lutetium 177 RM2, and you can see the pancreas, there is not much pancreatic activity in here, so because it washes out across time. And you can see the same, this is the SPECT CT of the same patients, and you can see there's a concordance between the lesions that you see on the imaging and on the Theransotics. All right, so there is some interest in this. There is a clinical trial that is going on. It's called COMBAT. And right now it's being looked at. Now for the imaging, copper-64 is being used, and for treatment is copper-67 that is being used. So this is a theranostic pair in RM2 domain. Now moving on, I'm going to talk about fibroblast activation protein. Now this is also a very active area of research right now. So you have a normal fibroblast that can change to what we call a cancer-associated fibroblast, and this can happen through a lot of pressures and signals you can see in here. However, this CAF does not have to come only from a normal fibroblast. It can come actually from any cell. It can come from adipocytes. It can come from a smooth muscle site. Different types of cell can become a CAF through different mechanisms. And when that happens, basically this is not good because this is really supporting the structure of the cancer for it to grow. So it participates in the immune dysfunction. It causes a better ability for the cancer to metastasize. So basically, it's like a mother, basically keep taking care of the cancer in a sense. And there are several different receptors on this cell that we can use for imaging or treatment. One of them is called FAP, the fibroblast activation protein, which is what I'm going to talk about. So here's the fibroblast activation protein. This is very similar to PSMA. It's a transmembrane protein with a very large external domain, just like a big antenna, just like PSMA, that you can use for imaging and for treatment. Here is this image has been probably shown 1,000 times in different conferences. This is from Germany. They looked at gallium-68, the inhibitor of FAP 04. This is their compound 04. And you can see different cancers. This is sarcoma, esophageal cancer, breast cancer. We even have prostate cancer down here. That shows all these abnormalities which are based on this fibroblast activation protein presence in different tumors. So this is what's called the pan-cancer imaging, but just like FDG essentially. Now there has been studies looking at imaging of this. For example, you can see in prostate cancer, here's a zirconium-89 labeled antibody against the FAP. And you can see that regardless of what the tumor is like, whether it's in the different tissues or it has been treated with different things, there is a high FAP content. And you can actually image that. So that's very good. It doesn't depend on type of treatment. It doesn't depend on type of tissue. You can actually start imaging. So these preclinical studies, you can see there's a lot of uptake in this tumor, in this animal, which is prostate cancer. Now, this is also showing that you can use this same tracer to, again, in patients with cancer-resistant prostate cancer. Even in neuroendocrine transdifferentiated prostate cancer, there is a high uptake in neoadjuvant hormonal treatment, in treatment-naive, pretty good uptake. And you can see 3 different patients that you can see disease scattered with using this type of tracer. Now, this is one study that actually compared PSMA, FDG, and FAP in the same patient. And in some cases, PSMA had shown more lesions. This was better than FDG and FAP, but there was some concordance. You can see FAP positive, FDG positive, PSMA positive. But in some patients, you can see the PSMA shows less than what FAP and FDG shows. So a lot of heterogeneity, again, in prostate cancer. Now, there is an interesting, this is an interesting also paper that came up with a bispecific Okay, so you can see that PSMA is positive tumor here, not here, and then here's FAP positive, but not here. But then in this new construct, you can have both uptake present. So with this new tracer, when you give it, you don't know if it's attaching to FAP or PSMA. If there is PSMA, it's going to be positive. If there is FAP, it's going to be positive. So it's basically dual targeted tracer. Very interesting work. Now here is, can you do theranostic? Yes. So here's Dr. Baum from Germany. This is not prostate cancer, this is metastatic breast cancer, but they looked at lutetium-177 FAP 2286. Just tells you how many agents they had to go through. This is 2,286 agents before they got to what it works. And you can see that they were able to image the patient, and patient got treated with FAP. This is another one. Again, this is not prostate cancer. This is pancreatic cancer, 3 patients, sarcoma, 6 patients from Germany. They looked at yttrium-90, FAPI-46, and you can see that these patients, this line basically, these are the swimmer plots showing how the patient was treated with different cycles here, for example, here, in this patient, and they were living long in some cases using this treatment. Okay, moving on to prostate stem cell antigen. Now this is, it says a stem cell, but it has nothing to do with the stem cells. So it's a kind of a misnomer, just like PSMA. It is, again, so it's not a marker of cancer stem cells, but it is present and overexpressed in prostate cancer, just like PSMA. And there's a lot of interest going on with this. You can actually This is a patient with lutetium, not patient, sorry, these are animals, lutetium-177 PSCA that was basically using this antibody to this target, and you can see that there is a good localization in the PSCA positive disease or tumors compared to the ones that are negative, and therefore there's a lot of interest in this too. This is another one looking at imaging using zirconium-89 or I-124, and it turned out that I-124 is better for looking at this PSCA. Can you use it for treatment? This paper looked at the Ostatine 211. This is alpha therapy, and you can see that when you give the treatment, the tumor growth is inhibited as opposed to control, which is not inhibited. So you can again use the PSCA for treatment. Moving on to cluster of differentiation 46, CD46, very interesting. This is considered to be a negative regulator of the immune system, and it expressed in neuroendocrine tumors, prostate tumors, and castrate-resistant tumors and primary cancer. And in fact, it's being used researched actively at University of California, San Francisco. Here's Rob Flavel, who's the chief of nuclear medicine at UCSF. And you can see here, this is a Western blot. Here's his PSMA. These are adenocarcinoma, and they all express PSMA, you can see in here. But the neuroendocrine prostate cancer, there is no PSMA expression. But the CD46, it's expressed across all of these cell lines, both adenocarcinoma and neuroendocrine prostate cancer. Therefore, this is very useful in patients with all types of prostate cancer, and studies are ongoing right now. Another one very interesting, delta-like ligand 3, DLL3. This is another one that has been received a lot of attention. This is labeled with zirconium-89 using a small fragment of antibody, and they showed, at least in this case, in one patient, a large tumor becoming a smaller using this what's called a bispecific T-cell engager, or BiTE, that basically directs the T cells toward this DLL3 expressing cells, and basically tries to eliminate them. You can image that by zirconium-89 label. Then human kallikrein 2. Human kallikrein 2 is basically a cousin of PSA, prostate-specific antigen. The PSA is kallikrein 3. This is kallikrein 2. So they are brothers of each other, essentially. And here is, you can label it with lutetium-177. This is an antibody showing you that as time goes on, from 4 days to 14 days, the tumor is getting smaller and getting better. And there's, in fact, a clinical trial going on with this right now. This is a phase 1 study that is looking at this labeled with actinium-225 alpha therapy with antibody targeting the human kallikrein 2 in metastatic castrate-resistant prostate cancer. So very interesting trial, and we hope to see these results soon. I'm getting to the end. Then there's another one, it's very long. 6 transmembrane epithelial antigen of prostate 1. It's called STIP1. Again, labeled with zirconium-89. You can see that it does get to prostate cancer. This is out of Memorial Sloan Kettering Cancer Center in New York, and they're looking at this as a potential imaging and theranostic platform. Then we have the CEA-CAM5, carcinoembryonic antigen-related cell antigen molecule. Here is another one labeled with zirconium-89 with an antibody, and you can see the images that we are able to image. Even in neuroendocrine prostate cancer, you can image this platform. And finally, thymidine kinase. This is my work. We're looking at cellular proliferation. Especially, we are interested in TK2, thymidine kinase 2, which is in mitochondria. for cellular proliferation. There are many tracers. You have heard of FLT before, but FLT goes to bone marrow. We designed something called FMAU, very similar to FLT, but it does not go to bone marrow. Here is the images of that from our laboratory, looking at mouse. Here's a dog, here's a monkey, and human. I wanted to see if there is androgen modulation of FMAU, and in fact there is. So here's mice studies. These are mice with non-castrated disease. You can see different organs, either muscle, heart, or liver uptake of FMAU. And here's the castrated animals. And then we give them the dihydrotestosterone pellet, and you can see the uptake goes up. So there is some modulation of androgen of FMAU uptake. We continued that work to see if the docetaxel-induced cellular proliferation with prostate tumor-bearing mice can be imaged with FMAU PET. And we saw that you can image it, as you can see in these mice. However, we have to continue this work to find out where is this signal coming from. Is it coming from the proliferating cell, which I think are inflammatory cells or healing cells that are coming to basically clean up the dead cancer cells? I think that's what's going on, but we have to continue this work. And finally, the last item, vicrostatin. This is integrin-based. There are many, many integrins which are participate in cellular adhesion and metastatic potentiation. We designed something called this integrin. This actually was first isolated from a venom of a viper, a snake. But you have very small amounts. So what we had to do was we did a recombinant genetics to make a lot of it. And the good thing about this integrin is that it can target multiple integrins. You can see that these 3 different integrins in here. So we designed this copper-64 agent. This is a SAR cage where the copper kind of sits in the middle, and we imaged the mice, compared this new tracer to the standard RGD tracer, and we found out that ours is better. So this is another interesting platform using integrins. So potentially we can change this CO64 to copper-67 for Theransotics. So that's what we're going with this. And the last slide showing you there's a lot of interest in non-PSMA prostate cancer. I mentioned to you gastroenterolysing peptide receptor. That's the most studied ones. But there are many others, and this field is evolving very fast and is very interesting. And with that, I acknowledge my funding from different sources, including the NIH. And as they say at USC, fight on.